Welcome to the Dementia Care on Air podcast series. I'm your host, Anna Chodos, the Executive Director of Dementia Care Aware. The goal of this podcast is to bring you short educational moments that will help you detect dementia and care for people living with dementia. And we're especially focused on how we do that in the primary care environment and the real world. We're going to have a lot of information that mimics what we have on our website and in our other educational modules. But we're also going to have conversations with experts and other people in the community in the field of dementia care that just help us do a better job in caring for people living with dementia and connecting them and their care partners to the things they need. Hello, everybody. Welcome back to Dementia Care on Air. And I'm very pleased to have my guest with me today, Michelle Panlilio. I will let Michelle introduce herself. Welcome, Michelle.
Hi, everyone. Good afternoon or good morning. I'm Michelle Panlilio. I'm a geriatric nurse practitioner, and I'm the National Lead Dementia Care Specialist for the UCLA Alzheimer's and Dementia Care Program. Thanks for having me.
Thank you for doing this. And you did two fantastic webinars for us on behavioral symptoms in dementia, or that's one way to talk about it. And there's a ton to talk about. You gave us so much good information. We're going to try to condense the two parts into this one podcast, kind of to keep the information all in one place, but we'll see where it goes. And if we have ideas for another podcast, certainly there's a ton of material here. But I guess we should probably just start with the basics, like what are behavioral symptoms of dementia and how do you usually talk about them and explain what those are?
Yeah, so behavioral symptoms in dementia, they really are the behaviors that make it challenging for families and caregivers to take care of the patient. You know, a lot of times in dementia, patients start off with forgetfulness, and that might not be as bothersome to families and caregivers until they start exhibiting behavioral problems, you know, such as agitation or aggression towards their family, depression, and all the other disturbances. And so, especially for patients who are struggling with dementia for a long time, these behaviors tend to get worse over time, and they also tend to get worse when the patients are not feeling well or if they are acutely ill. And so behavioral problems, we do a lot of assessments when it comes to these behaviors, only because one, it's problematic for the patient, but it is also problematic for the caregiver. So generally, and I think as I had presented during the webinar, the first and the second webinar, we like to use the tool, the Neuropsychiatric Inventory Questionnaire. And it's a tool that caregivers are supposed to fill out based on their observations of what has been happening at home with the patient. And, you know, I really love this tool. I rely on it quite heavily, only because it is probably the one tool that gives caregivers a voice of how bad things are at home. And it can be, you know, I don't know a lot of providers who use it and go into the depth and the detail that we do, but it does explore, one, the presence of the behaviors, two, how bad are they? How bad are they at home? Is it mild, moderate, severe? And three, how bothersome are these behaviors to the patient? Now, based on the discussions with the families, that usually it dictates where my care plan is going to lead into, whether, you know, we're going to talk about behavioral modifications, or is it any emergent issues, or do we need to start talking about potential medications that are going to address the particular and specific behaviors that the patient is having. So I think as far as like my conversation with the families, when they fill out this questionnaire, we don't just accept, you know, yes or no, the patient is having delusions. Generally, we go into detail. And so, for example, if we say that, you know, if the caregiver is telling us that the patient is having a lot of aggression, we'll ask them, like, what kind of aggression is it? Is it verbal? Is it threatening? Or at any point, has it gotten physical between the two of you in the past week or so? And that will open up, it'll usually open up a can of worms, you can say. And then moving forward, that's how we determine the plan of care.
That was great. Okay. So, because it really gave us an overview too of like how you're using these symptoms in the clinical care. And the NPI is sort of your guide to like, what would you say it's your guide to what these symptoms even are? Like, are there some behavioral symptoms that happen that aren't on that inventory, or is it really like a good place to start?
I think it's a great place to start. It's also a great place for the caregivers to really verbalize what's going on at home. So a lot of times they'll just clarify, actually, no, I did report that he is having some hallucinations, but come to think of it, he actually had it a couple of years ago. He's not having it anymore. And he had it a couple of years ago when he was acutely, when he was in the hospital. He's no longer having that. It also helps the clinician figure out, how bothersome is his behavior? Is his behavior that we can treat with behavioral modifications? Or is it really more appropriate to use pharmaceutical treatment for this behavior? Or it could be just patient education. So for example, I find that apathy and elation, although it is present and although it can be a little bit bothersome, most of the time families are not, they're not bothered enough so that they would want medical treatment for it. But it's just a way of kind of, putting their concerns out on the table so that the caregiver is aware that the clinician is aware that they're happening.
Got it. Oh, yeah.
For the NPIQ, also, I find that it's very good when you are trying to talk to families about their knowledge and also their expectations from the patient. So if the family is reporting that, let's say, for example, if the family is reporting that the patient is apathetic or they're no longer interested in bathing or seeing their family, then we kind of talk about what they can be expecting in the future. So it's a way of educating themselves about what is currently going on and what is kind of expected in par for the course of the disease and kind of what their future is bringing. So a lot of times it serves as education for them, kind of so that they know what to expect in the future.
I'm going to recap a little bit. There's this inventory really goes through the core behavioral symptoms that we see. And I guess broadly, I also think of it as like, this is a cognitive domain. And these are the symptoms that we see within that domain. These are changes from baseline. And the key components of the neuropsychiatric inventory questionnaire that you reviewed are that, one, it relies on a caregiver or an informant, and that in and of itself really kind of empowers that person to be part of the care process. That it assesses essentially if the symptom's present, but also how severe it is and like how bothersome it is, because that's going to determine where we go with a treatment plan, basically. Mm-hmm. And then, I think a challenge always about talking about this topic, and one that is part of the reason we split your webinars into two parts, is just how many behavioral symptoms there are. And so the ones in the inventory that I know you went over were like delusions and hallucinations, which are, so very common. You called it agitation, also aggression, kind of lumped together, depression or dysphoria, anxiety, elation and euphoria, apathy, indifference, disinhibition, or being impulsive and kind of inappropriate, irritable and labile, motor disturbances, so like repetitive behaviors and pacing, nighttime behaviors, and changes to appetite and eating. So every time I see the inventory and every time I talk and think about this, obviously every time I'm doing clinical care with someone living with dementia, these symptoms are so common, and like their breath, I know for me has always been something that I'm always kind of stunned by. These are really just a ton of symptoms and changes. And I know when I'm teaching, and one of the points of this podcast would just be to like point out just how many symptoms there can be. And this is partly why when you see data, you see that behavioral symptoms are, essentially 100% prevalent in people living with dementia. Like there's very few people that over the entire course of their disease won't have a behavioral symptom.
I also wanted to add that for clinicians, it's like, okay, how do we use the neuropsychiatric inventory questionnaire? We'll just call it the NPIQ for short. How are we supposed to use it in our real practice? I know that for me, when we are targeting a specific behavior, so let's say we're starting the patient on an SSRI for depression and anxiety symptoms. So after the family has completed the NPIQ, I have the habit of actually looking at the numbers and asking the families, what is your goal? Where do you want to get to? What do you hope to accomplish in about, let's say, 2 months? What do you want to see? And then I'll write it down. If the family is hoping, Michelle, I'm hoping to see that my mom is less irritable. Okay, then I'll document that. And I'll also look at the scores, whether the severity is like 1, 2, or 3. And then the distress for the caregiver is 0 to 5. And then we'll kind of work towards a goal of where we want to be 2 months from now. And then a lot of times it's helpful when you go back to what the caregiver is actually reporting after you've initiated treatment. And then they'll say, oh yeah, I do remember that 2 months ago, my goal was to get mom to be less irritable. And I think we did a pretty good job in accomplishing that. That could be a goal. I think a lot of the caregivers, they get very discouraged that these symptoms don't always all resolve. And so they might think that it's something that they did or something that, it's their fault, when it's really not. It's just a normal part of the disease. And so I think, aside from using the tool, like doing the behavioral modifications really empowers caregivers in controlling a lot of these behaviors. And they may not realize it until you've gone back like a couple of months after and say, hey, remember when we started this behavioral modification that you are now doing on a regular basis? I'll give you an example. Like one of the things that I love is when families come back to me for a follow-up visit and they report how much better the behavioral symptoms are. And then they forget that we were the ones who actually recommended it. But they're saying, oh yeah, you did recommend that. That's right. But guess what? I've been doing it. I've been successful, and we didn't even need to start any medications, and that behavior is already better. And so the way that the caregivers are able to reflect back on what they had initially filled out to what the patient is looking like 2 or 3 months later is very empowering to them. But also it makes them hopeful that they are able to do something, at home with a little bit of training from us, that they're able to do something to make that behavior better. I think I just wanted to add, when it comes to the NPIQ, what I tend to see are a lot of families, they'll report to us that, Michelle, everybody knows my dad has dementia. Everybody knows that. But you're actually the first person who's asking us about these behaviors. We assume that these behaviors are just a part of the disease and something that we can't do anything about. And so they're very appreciative that we are exploring just how bad these behaviors are. but also that we are talking to them and educating them that they can help make it better for the patient and also for themselves at home.
Yeah, that is so important that clinically we see that these symptoms have such a huge impact on people's lives, and that if we're skilled at addressing them, we stand to gain a lot in terms of rapport with patients and points for being helpful. I so agree with that. Just in terms of my own experience, that's a really good point. So you've done the assessment, you sort of have in front of you some sense of whether or not people are having certain symptoms, how serious they are, and how much people feel like they're affecting them. So I sort of agree with you too. There's somebody's having hallucinations, but nobody's really concerned about them and they're just kind of rolling with it. That may not warrant treatment of any kind, just acceptance. But for you, how do you start to decide if, quote unquote, if you're going to treat, and then how you're going to treat?
That's a great question. I think the question is to treat or not to treat, right? Depending on the severity of the behavior. Usually the first thing that I think about is safety. So if the patients or caregivers safety is compromised for whatever reason, then I tend to consider pharmaceutical treatments, like with either an antidepressant or an atypical antipsychotic. Usually what would warrant that is the patient's safety or the caregiver safety being compromised. What I usually do also, if it's my first time meeting the caregiver and the patient, meaning for an initial consult, I will spend some time, if safety is not being compromised, I'll spend some time providing them a lot of education, meaning where is this behavior coming from and why is it happening? And then starting off with what they can do. So giving them some recommendations for what to do at home without the use of pharmaceutical treatments. And then after that, maybe 2 or 3 visits later, depending on how the behavior is impacting the patient's everyday life and their quality of life, then if it continues to worsen over time and the family is, actively implementing all of these behavioral modifications at home and it's not working and it's very resistant, then I will tend to start discussing medications with the caregivers.
Can you elaborate a tiny bit on what you mean by safety? Like, how do you know if people aren't safe?
Yeah, so I have a few good examples. So I think let's talk about hallucinations, for example. Let's talk about hallucinations. I try to, when I'm talking to the family, I try to differentiate what is, bothersome versus not bothersome, and safety versus okay. So I have a patient, who for a long time, she had visual hallucinations. And her hallucinations were of children, small children in the afternoon, and they would come over to her house and they would just be playing. And the family reported to me that they were very bothered. They were very bothered by this behavior. They didn't know why it was happening. And so my question to the family, is how much does it bother your mom that she's having these hallucinations, that she's seeing these small children? And their answer was that no, it doesn't bother her. It actually makes her happy. And then come to find out that the patient is a retired teacher. She was an elementary school teacher. And so it certainly wasn't bothersome to her for her to see kids in the afternoon. Okay. So after I found that out, I said, okay, and what does mom do when she sees these small children? And their answer was that nothing. She just sits there. She sits there and she just watches the kids. And sometimes she'll talk to them. Sometimes she'll ask if they have food, if they have, if they'd eaten for the afternoon. And that's all. And so I talked to the family and I said, listen, just because she's having these hallucinations does not necessarily warrant treatment because it's not bothering her. So that's one example of when I wasn't worried about mom's safety. And so we let it go. Just a little bit of education and counseling and guidance for the family. And they were perfectly happy with that, perfectly happy with just me explaining to them what was going on. Well, another example is I have of this patient who was also having hallucinations. Now, this was also a patient who I had met for an initial consultation, and the family had come to the office. They're very, very, very distressed. Come to find out that their mom, she owned this home, which was beautiful, had an ocean view. It was a home that the kids had grown up in where she raised her family. For the past 3 years prior to me meeting them, she had been living in her car. And past 3 years that she'd been living in her car, which was just parked right outside of her house, she suffered, I think, 2 or 3 DVTs, and she had a couple of pulmonary emboli, lots of urinary tract infections. And I said, okay, so what's going on? And the family reported to me that mom was not going into the house because she was seeing demons at home. And so the only time that she would actually physically go into the house is if she had to get water or if she had to use the restroom. And that was it. So that was the reason that she was living in her car, because she was afraid to go in her house. And so long story short, given what had been going on past 3 years, all of her medical problems, that had ensued because she was refusing to go into the house, then that was more of a safety concern. So for that particular reason, aside from, implementing some behavioral recommendations for the family, such as hiring a caregiver, then at that point, I did start her on an atypical antipsychotic almost immediately, with obviously after speaking to the family regarding the box warnings. And so that's when, I immediately started somebody versus just educating the family on a symptom. And so, thankfully, she responded well to treatment. And I think the last time I heard from the family, she was doing Zumba classes. So, it just depends on the severity and how bothersome it is for the behavior, as well as any safety concerns.
And just to be crystal clear, when you look at that score from the NPIQ, does that necessarily point you in a direction, or you're still kind of getting more information about, the scenario to kind of determine if it's worth the pharmaceutical intervention?
Yeah, that's a great point. So when I'm looking at the score, yes, I'll look at it, but then I don't just take it for face value. I do want to make sure that the family understands how to complete it appropriately, and that the behavior, so let's say a hallucination, is a true hallucination. I think, speaking of hallucinations, one common behavior that families report is that, oh yeah, my mom will talk to her sister, and her sister's been dead for 10 years. And that's not exactly a hallucination. And usually the family is not sure that the patient is seeing somebody there. It's just she's talking to somebody there. And so I don't just take it for face value. I do ask more about the behavior that they're reporting and the actual score.
Okay. And I know we probably want to dig in a little bit on like non-pharmacological treatments for behaviors, but I just kind of want to point out, you've mentioned a couple of times, because it makes sense in the sort of clinical assessment and care planning, there are these medications and we use these atypical antipsychotics for serious behavioral symptoms. Or I think you were pointing out that if maybe it's more mood or anxiety predominant, that we might use an SSRI. I'll just make the point, and you can correct me, that in general, we look to use antipsychotics we certainly tell patients and any other decision makers that these are medications that come with a black box warning in the case of the antipsychotics, because they do lead to premature cardiovascular, cerebrovascular events and death. But we use them at low doses, and we, typically try to use them only in these scenarios of severe symptoms that are causing a lot of distress or safety concerns. And and I think a lot of the common ones that I see are Seroquel, or quetiapine, Abilify, or I'm not going to remember the non-brand name.
Olanzapine as
well. Or
olanzapine.
Yeah. Okay, there we go.
Yeah.
And I don't know about your practice, but I've often been told, just to schedule it around the time that the behaviors are most prominent, and not to always do a PRN approach, mostly to see if there's an effect and make sure that there's some consistency there. What is your approach?
I have the same approach as you. I think, we're both coming from geriatrics, in that we start low, meaning the lowest dose possible, and we go very, very slow as far as titration. As when you're having the discussion of atypical antipsychotics with families, it sounds really harsh. It sounds really harsh to hear. And so, I'm not surprised that it usually takes more than one conversation with caregivers to be able to convince them that this is perhaps something that we should try. When I'm having those conversations too, I'm very mindful that for families, it's not easy to put their loved one on an atypical antipsychotic. And so usually if I'm starting this, I will have the conversation with them saying that, listen, today we decided to start mom on an antipsychotic. That doesn't mean that I'm going to see you in a year. So I would like to see you in a couple of weeks, whether that's via telemedicine or telephone. And, I hope that we are able to speak to each other at least once every week or a couple of weeks. It just depends. My intent is that in a matter of 3 months, depending on how your mom is responding to this medication, my hope is that we're able to eventually cut her doses down or wean her off completely. That is my hope. And then, just like you, when we're talking about atypical antipsychotics and how they're, meant to control the patient's behaviors, we also talk about the goals of care. Meaning, the last time that I talked to you and your family, you told me that your goal was to stay at home. And so I want to help you do that. But in order for you to stay at home, we have to make sure that you are safe and that you're not hurting yourself or other people. So we're starting this medication today, but I'm hoping that it's something that we can cut down over time. And I'm hoping that it's able to give you a better quality of life for you and your mom. That's usually what I will say to the families. And then I do follow up. So for our patients in the ADC, generally, if you're starting a patient on an atypical antipsychotic, it would not be unusual for us to have like a weekly visit, whether telephone call or telemedicine, with a family until the behaviors are stable.
That's awesome. I really appreciate that you kind of share the language that you use with people, and also that you sort of tie it to, there's a bigger picture here. We're trying to manage these symptoms in the context of kind of what's most important right now for you based on your words, your goals. And you make this a really active clinical issue. We're going to talk soon. We're going to work on this actively. This isn't a, prescribe and see you later moment. Exactly. Well, this is great. I think this has been an incredibly helpful review around the pharmacologic part. I know that the non-pharmacologic part is actually kind of harder for a lot of us as clinicians. And is there a way you can kind of highlight for us the big take homes on how we should be trying to manage folks around behavioral symptoms non-pharmacologically? Like, how do you kind of dig in on this with people? And yeah, it'd be great to hear more about that.
So I think, when I'm talking to families and trying to educate them, it's important that one, you acknowledge that these are happening and acknowledge how, for us clinicians anyway, acknowledge how it can be very bothersome for caregivers to deal with a patient at home. I think the highlights of what I would say is that whenever we are dealing with behavioral modifications, it's something that we continue to revisit with the family and pretty much at every single telephone call and every single visit, because we do understand this is what makes it challenging for them to do their day-to-day stuff at home and continue to provide care for mom and dad at home. One of the other things that perhaps this is for both the clinician and the caregivers, this is not behavior modifications and behavioral problems can be very resistant. And so if these behaviors keep on continuing, or if they're getting worse, just be patient and understand that these challenges are happening not because of your fault or the caregiver's fault, just because it's a part of the disease. And so what that means is that as a clinician and as a caregiver, you're going to need to continue to revisit these behavioral problems over time, just to make sure that the caregivers know that there's help out there, that they're not in this alone. There are other people. And so even after the behaviors have improved, make sure that you follow up and that you are giving other recommendations to the families, whether it's, attending a support group or perhaps private counseling, or simply educating themselves on what these behaviors are and what else they can do at home. That would probably be my biggest point. Just keep on revisiting it until it's better. Generally, when I'm talking to caregivers, let's say like 2 weeks after, they started medications or they started some kind of behavioral modification, my usual go-to question is, since we last spoke, is the anxiety better, same, or worse? And then depending on how the caregivers answer me, then that's how we would move forward with whatever are the next steps for the caregiver and the patient.
Ooh, that's awesome. Thank you. That's so good. I'll just kind of reiterate and kind of review. So we have an understanding of what the symptoms are with the questionnaire that we've done. And then we're sort of giving people resources and ideas for how to manage it with, you're saying behavioral modifications, and I've also heard it referred to as behavioral interventions, or sort of training for the caregivers on how to manage the behaviors. And then we're checking in about it each time. Is it better or worse? Have we gotten somewhere? And I've also definitely seen some teaching around, to support what you're saying, documenting the trials, like the things they've been working on, and really approaching this a bit experimentally. Like, we've tried this thing, it's not really working. Like, a good example is, resistant behavior to self-care. And, people come up with, okay, well, I tried convincing her it's a spa day once a week and we do this thing, and that, she wasn't buying it, and so we know that doesn't work. We're not going to go back and try that. I think a daunting thing for a lot of clinicians is, how do I really give people advice about how to manage these behavioral symptoms? I think it's a lot to ask personally, a clinician who's got a million other things and doesn't have training in this, to all of a sudden be an expert in this. But I guess just like one or two quick tips that you often give people for how they can find that help somewhere else. Like, I know I often refer to Alzheimer's Association or other support groups, sources of education, and knowing that it's not something people have a ton of time to dig into, but when they're ready or when they're able, they might. So I want to keep bringing it up. Is that a good strategy, or do you have other tips?
I completely hear you when it comes to clinicians, especially PCPs, geriatricians who have only 15, 20 minutes to see their patients. I think if you're in that type of a setting, my recommendation is to target one behavior at a time, and probably the most bothersome and problematic patient for the patient and the caregiver, and then revisit and continue to revisit the other problems with the caregiver. I mean, as far as support groups, I think they're incredibly helpful and they're very powerful, not just for the person to be able to verbalize their thoughts and their questions, but really to learn from each other. The people who typically will attend support groups like ours, they form relationships, and it's like deep friendships that they have with each other, that it's just kind of like they develop these friendships over support groups, and generally will continue to have those friendships long after their loved one has already passed away. So I highly encourage, we all encourage our patients to join support groups.
Wonderful. Yeah. And I always say, I wish I had the best advice, but I probably don't for your situation. And I've not been in your exact situation. So this is where you find people who maybe are a few steps ahead. And that's something I like to emphasize. And frankly, I think it's still really hard for caregivers to always find the time, but it's and just in case that helps anybody, that's how I tend to frame it for patients. Michelle, we could clearly talk about this forever. My goals to condense everything into one podcast have been dashed. We're definitely going to have to do another conversation. I think it would be great to really focus on some of the more tips on walking patients through and their caregivers through, including paid caregivers. Like sometimes I find paid caregivers are still struggling to manage certain things. But regardless, walking people through how to really be different around people with dementia so that their behaviors are different. The real intervention here is the caregiver. So I think it'd be so great. So we'll plan that. But in the meantime, I cannot thank you enough for being here today, to sharing your tips, and for the wonderful webinars that you did that we hope everybody also gets a chance to watch if they're more curious on this topic, and are available on the Dementia Care Aware website and YouTube channel. But Michelle, thank you so much. Your commitment to patients and the work that you do is incredible, and so grateful to talk to you today.
Absolutely. Thank you so much for having me.
Thank you for listening, and to our wonderful guests. And a big thank you to our administrator and everything doer, Rita Archikova. Also, thank you to our audio editor and voice specialist, Lisa Costello. And we want to make sure you know you can get CE, CME, and MOC credits if you go to our website and click through to the podcast page, where you can do a quick quiz to claim credit. This is all possible through support from the California Department of Healthcare Services and the hard work of the Dementia Care Aware team. If you want to learn more, please visit our website, dementiacareaware.org.